Yes, now, President. Yes, now, I am from the passport in the country. It's a play, but in there, a day.
I had lost all of my.
And hello, good evening, and welcome to this Joy News special thought leadership event live from the studios of Joy News and Joy 99.7 FM. This whole week here at Joy News, we have focused on a crisis that has left many families devastated, the dialysis crisis. A largely underreported subject grabbed national headlines when the country's premier teaching hospital announced an increase in the cost of dialysis. There was an uproar, but we decided to go beyond the headlines to examine a problem that is a symptom of a much bigger challenge with Ghana's healthcare system. Tonight, we bring together patients, caregivers, policymakers, and citizens to explore for solutions. My name is Evans Mensah, your host from the Joy News studios. And also joining me to co-host this particular thought leadership event is, you see him on the screen. To co-host this particular thought leadership event is, you see him on the host this particular thought leadership. Doyang Singh, who is in the Joy 99.7 FM studios with our host of panelists who will be joining us. We start tonight by pausing to remember 15-year-old Priscilla Asante, a brilliant and hearty pupil of the Mampon Catholic Basic School. Priscilla died on Sunday, just 2 days after we recorded her story and her desperate plea for help for our dialysis crisis series. Priscilla dreamt of being a nurse. That dream died with her because she and her family simply could not afford dialysis treatment. Tonight we remember her and the many others suffering her condition, whose story has inspired tonight's conversation.
Yes, now, President. Yes, now, I am from the passport in the country. It's a play, but in there, a day.
I had lost all of my.
It's not easy always chasing people or asking people for help because it is very difficult to sustain. And this is a disease that you always have to be coming to the hospital. Without that funding, you can't come for dialysis. And here is a case that it is a pay as you go.
My mom and dad do not have money either. We have become miserable. I am appealing to the government to help me live through this. Otherwise, I may die.
They said that could be a 3.5.
They say every session is 350 cedis.
You know the harsh economic conditions now, so I have to beg before I get money for my weekly dialysis at this private facility.
We are pleading with government to help us with the dialysis. We cannot pay because of that. We are not able to go for dialysis, and that one too is our strength. If we don't do the dialysis, we are suffering. We are pleading them to help us, pay the money for us so that we can dial at least 2 times or 3 times a week.
I
want the government to support me so I can live to fulfill my dream of becoming a nurse.
I lost my lovely daughter Sunday dawn. She bloated due to her failing kidneys and died in spite of the dialysis. My heart is heavy and I've incurred debts in my quest to keep her alive. We are ordinary farmers. My husband and I have been left with nothing. We must pay 4,000 Ghana cedis in order to claim our daughter's body from the hospital tomorrow.
Very good in academics. She also participates in sporting activities in the school, and she is friendly. She is punctual, respectful, and very calm.
Our condolence to Priscilla's family. So, can Priscilla's story inspire change for others with her condition in a failing health system? And how do we ensure that? Well, joining me tonight for this conversation, Dr. Nsia Sari is a presidential advisor on health and former director general of the Ghana Health Service. He will join us pretty shortly. Perpetual Ofori Ampofo is the president of the Ghana Registered Nurses and Midwives Association. Well, she and her members, they are caregivers. They see these patients on a daily basis. Some of them know they can save them, but of course the challenge is many of them lose these patients. And she's here to give us a sense of the national picture. She's in the studio with me. Also joining us tonight is Kwame Sapon-Asiedu. He's a pharmacist by profession, a Democracy and Development Fellow in Public Health at the Ghana Center for Democratic Development, CDD. Professor Samson Entry, president of the Ghana Kidney Association, professor of Child Health and Pediatric Nephrology at the Kwame Nkrumah University of Science and Technology, KNUST. Dr. Opoku-Ware Ampoma is the chief executive officer of the Kolebu Teaching Hospital. We're expecting him to join us pretty shortly. We also have the National Health Insurance Authority. Oswald Isiam-Mensah is the director of corporate affairs. He will also join us. Later, we'll hear from Dr. Titus Berry. You know him. He's a former general secretary of the Ghana Medical Association, worked extensively in rural hospitals, particularly in the Upper West region, currently running for parliamentary seat on the ticket of the NDC, of course, in Lambushi constituency. Kojo also has his own set of guests with him in the studios of Joy 99.7 FM. Kojo. Well, we'll get Kojo. You can hear Kojo's voice pretty shortly for those of you on Joy 99.7 FM. And if you're watching us here on the Joy News channel, you saw him there. He will definitely get to hear his lovely voice in this conversation. But he has with him a number of patients, kidney patients. Kojo Bafo Henkra is end-stage kidney failure. That's a challenge that he's been battling with, being on the treatment for 8 years. Thomas Vincent Can, you saw him featured in our series, a kidney patient also on dialysis for more than a decade. James McKeon Amwa is a senior nursing officer at the renal dialysis unit at the Kolebu Teaching Hospital, a national organizer of the Ghana Public Health Association, representing the Ghana Health Service is Dr. Fred Adomako-Boateng. He's a regional director of the Health Service for the Bono East region, and he is also with us. So this is a very comprehensive conversation indeed. And wherever you are, please join the conversation. Dialysis crisis, go onto our many social media platforms. We'll bring your views into it as well on Twitter, on Facebook. We're also live on YouTube for those who are not watching us live here on the Joy News channel. I want to start tonight with Kwame Sapon-Asiedu. Kwame, why is this a crisis and how deep is it?
Thanks, and good evening to everybody. Yes, it is a crisis. I want to paint a picture, Evans, as to why this is a crisis. So I want to put this in context to set the stage. Based on current research, it is estimated that between 13% and 17% of Ghana's population have some form of renal function impairment. This equates to between 4 million and 5.2 million citizens. These researchers suggest that from this segment of the population, between 15,000 and 19,500 Ghanaians should be on dialysis. The data available suggests that only 2,000 people are currently on dialysis. This means between 13,000 and 17,500 people are without treatment. These people would often seek alternative forms of treatment and access renal care only when the situation is acute. This has an impact on the quality of life and their life expectancy. All research suggests that the prevalence of chronic renal disease in Ghana has approximately doubled in the last 10 years, with cases across the entire span of Ghana's population age profile. According to the Ministry of Health, Ghana's outpatient per capita is 1.06, suggesting that on average, Ghanaians see a primary care clinician once a year. In proactive health systems, this figure is around 4. Citizens see a clinician once every 3 months. The fallout is that for the majority of our population, there's only one chance a year for any diagnosis of renal failure to be made, except in an emergency. Whilst in proactive health systems, there are at least 4 chances to identify these patients. Across the country, the total number of dialysis machines is approximately 300, with the majority in the Greater Accra and Ashanti regions. 4 regions do not have a single dialysis equipment. Citizens in these regions requiring dialysis must commute significant distances to seek care. The cost of dialysis in Ghana ranges from 300 cedis to 1,000 cedis per session. The median cost in government and quasi-government health facilities is 400 cedis per session. The range is between 300 and 600 cedis. The average number of sessions required a week is 3. This means a patient requires approximately 1,200 cedis each week just to stay alive. If additional routine medication is added on, an extra cost of 435 cedis is required weekly. This brings the weekly cost to the patient to 1,635 cedis, assuming they have no underlying conditions such as hypertension or diabetes. This means the annual cost of staying alive for these patients is 85,020 cedis or 7,085 cedis a month. According to the Statistical Service of Ghana, 70% of working Ghanaians earn less than 3,000 cedis a month, or 36,000 cedis a year. This means, should these workers or their dependents require dialysis, they would require 2.4 times their annual salary just to stay alive. That is assuming they are not eating, they are not paying any bills. The practical implications of this number is that over 90% of Ghanaians are priced out of dialysis care based on earnings. Could this explain why between 13,000 and 17,500 people requiring dialysis are without care? Evans, this is the reality of the crisis and the scale of the situation we are confronted with.
Bring in Professor Antwi, and Prof. Antwi is with the Ghana Kidney Association. He's a nephrologist himself. And Prof, you see this on a daily basis. From all the things that we've just heard there from Kwame Sapanasiodo, what do you consider to be the single most important challenge that kidney patients face currently among the whole list and the raft of things that we just heard, articulated by Kwame?
Thank you very much, Evans. And good evening to my co-panelists and to the listeners. So we are happy that this discussion is coming up because over the years, we have been very much worried about the challenges that patients with kidney disease face in terms of cost. And so as has been articulated, we pray that people with kidney diseases don't get to what we call end stage. You know, there's a whole spectrum of kidney diseases. You can be diagnosed with kidney disease. You have 5 stages, and you can be managed. Stage 1, stage 2, up to stage 5. Once you get to stage 5, it means your kidney is no more functioning. The function is just down to a halt, and therefore, if you don't get artificial kidney, you will die. And we know everywhere in the world that the cost of treatment for getting artificial kidney, what we call kidney replacement therapy, i.e. dialysis or kidney transplant, is so expensive. Yet, that is the solution. There's a solution to what would otherwise have been a dead end. If medicine have not found that solution, what we call kidney replacement therapy. Anybody with kidney failure will have died. But then there's a solution, there's a medical solution. But the single problem is that the treatment is so expensive. I think Kwame has actually talked about some of the cost items. We'll come to them in detail. But the treatment is so expensive that everywhere in the world, we don't allow people to pay for the cost of kidney replacement therapy from their pocket, because we cannot afford this if you allow people to pay out of their pocket, even if they have a lot of money. And so affordability has been the major challenge. And this has existed over all these years, I can tell you. And it is something that it is so dear to us as an association, how we can get these things affordable. And so I think what has triggered this discussion has been the attempt to increase the price. I think we will come to, in the course of this, we come to the pro and cons or the justification for this. But even at the old price of that they were charging, 300 and something 50 Ghana cedis per session, I can tell you that probably only a third of people with kidney failure were able to initiate dialysis. The majority of them, probably 2/3 or more, were dying. When we come to children, it is a rather pathetic story. My condolences to the 15-year-old who passed Sunday morning. And I can tell you that because the cost of dialysis is so much, a few adults are able to afford, but they don't even afford it to the maximum spectrum, what will give them the best of care 3 times a week. Because of course, some people take it just once a week, so it's not good for them. Some take it twice a week. Only few are able to afford it 3 times a week. When it comes to children, it's pathetic because we don't have any facility for children. And where I practice, for all these years, any child who gets to the end stage kidney disease dies. And the number is quite huge. And so my condolences to the girl who passed, but there are many more who also pass in our health facilities. All the children die, and many adults can also initiate it. So the single problem has been the cost of treating kidney failure. It is so expensive that we should not allow people to pay out of their pocket. And I'm happy for this conversation. Probably something will come out of it. Thank you.
We touched on the subject of children dying and children also with kidney problems. You say that they also die in their numbers. Do we have?
Oh yes.
Do we have
yes.
a fair sense of these numbers? I know the experts in the field from KNUST, Dr. Tinkran and others have done a study. Do we have an appreciation of the numbers when it comes to children affected by kidney challenges and the numbers possibly in stage 4 who will need urgent intervention or may die?
Yes. So I myself am a kidney specialist for children.
Okay.
And so definitely I can provide you with these statistics. A publication I did earlier on in 2012, the prevalence of kids who have kidney disease in hospital, not the population, was about 4.3 of all kids who are admitted to hospital facility. About 4.3 of them have got kidney ailments. But most of these can be acute. For the acute kidney ailments, the kidney will recover if you give it some time. But of course, if the person's kidney fails and the toxins are building up and you are not able to perform dialysis acutely, he will die. But the good thing is that you do those dialysis, it doesn't take a long time, probably 2 weeks, the kidney will recover.
Okay.
And you stop the dialysis. So people do it. But for those who have got the end stage, which is a chronic process, what we see in Confanoche, take note of this statistics, it's quite startling statistics. We see every year between 25 to 40 children who come with end-stage kidney disease, and they will all die because, of course, we don't even talk about initiating chronic dialysis. Adults can probably afford to start some dialysis, but not for children. It is so expensive that all the children with the chronic one, which we call the end stage kidney failure, all of them die in Ghana, every child. And so I was not surprised that this child that reported about, even he started a bit of dialysis, but will he have sustained it? How long was he going to do the dialysis? For 6 months or for 1 year? And so they all die. That's what happens. It is so painful for us as practitioners to see in the world, sometimes in a week, I can see 4 children with end-stage kidney disease at a particular time, 1 week in the world, and definitely they will all die. So we see between 25 and 40 children every year with end-stage kidney disease. That is only in my hospital. I mean, the nation, if you extrapolate it, I said that the prevalence we had from one publication we did was about 4.3%. So that is the quantum of children who got kidney ailments and those who get ends. Yeah.
And we mean the studio association, those numbers are startling. And yourself and your members will be obviously providing the care for them. Just at Confanoche, 25 to 40 die each, and when they come at that stage, almost certain that they will die. That must break your heart.
That we find ourselves in. And to think that children, Ghanaian children, cannot live their full lives to actually attain their dreams for the future, just like Priscilla, who wanted to be a nurse like myself. It is really, really heartbreaking. And we see these patients on a daily basis struggling to be able to go through the dialysis. And first of all, it's an issue of access, it's an issue of cost. But the most difficult part is also the psychological trauma that they individually have to go through, the impact it has on the family, and the kind of issues that actually comes about just because one individual in the family has been diagnosed with end-stage kidney disease and has to go through dialysis. People have become very poor. Although their previous situation was even not the best, they have become very poor just because they are supporting a family member to go through it all. And these are really, really difficult situations. And for us, we are happy that this conversation is going on. And just like it's been said earlier, these have been going on for years. It's been going on for years. And we should be thankful that maybe now is a wake-up call. But we hope the conversation doesn't end. Absolutely. With this item, it's more like a policy dialogue that you are trying to do here.
Yes.
And it shouldn't end here. There's more to be done because as a nation, we should be hitting ourselves and asking ourselves why we cannot provide healthcare. For me, I think that the National Health Insurance should be able to support all these patients if truly what we are generating from the NHIS is applied for treatment, solely for treatment. Not when decisions can be taken for such monies to be put into other things rather than health. And when you look at the economic situation that we generally find ourselves in, it's just a small number of Ghanaians can find themselves in the high income earning zone, with a few in the middle. Majority actually are in the lower economic situation or belt where their daily income is such that it cannot actually support this kind of treatment.
Up to 1,200
exactly
a week.
A week.
And Kwame Sapasiru puts it, if you add medication to it, you are in the ring of 80,000
exactly
a year.
And
how many of us can
afford it? Even those of us who are working and receiving monthly salaries, how many of us can afford it? So I think we need to delve deeper. And, non-communicable diseases has become a world burden. The fact that more people are getting diabetes mellitus, more people are getting hypertension, and these existing conditions can result in that. Even extreme malaria can also result in this. Aside the alcohol and what we know as the herbal intake, which are not actually properly standardized by the Food and Drugs Authority and all of that. And it will amaze you to know we live in a country where people can still buy drugs from people who are selling it in some boxes or in a pan. And you can never ascertain the quality of these drugs, and they can also have an effect on our kidneys in terms of whatever it is that we are taking in. So the data that has been churned out is important, but we need to scrutinize further, and we need to build more data in terms of the causes, what is causing a lot more of these to be coming up. Because we are talking about this for our patients, but we are not left out as even health professionals.
And indeed, I have a renal nurse who will join us pretty shortly with Kojo. But I want to quickly, since we have Dr. Mpoma in the studio, and Dr. Mpoma is the Chief Executive of Korle Bu Teaching Hospital. As he's been said, it's the announcement that Korle Bu was going to increase, or has increased, but people were charged that, the cost of dialysis that had triggered this whole conversation, really. It got the nation to sit up and pay attention. It's been more than a week now. As a chief executive, reflecting on that, I wonder what your feelings are now that we're having this conversation, we're having a policy dialogue on this going forward. Any regrets from where you sit that was even a conversation that started because Korle Bu announced an increase and actually charged people for it? What has been the reflections over the last 1 week? I'm curious to know at Korle Bu and yourself.
All right, thank you very much. So let me begin by saying that I need to set some of the records straight. Okay, so this conversation is something that we've been having in the hospital for quite a while now, in terms of the sustainability of renal dialysis as a means of treating patients with chronic kidney disease. Now, let me also situate Korle Bu's, where the role that Korle Bu has played. At the last count, we had about between 700 and 900 patients in the entire country who are on regular dialysis. Okay, now, out of that 700 or so, around about 300 to 350 are treated at the Korle Bu Teaching Hospital alone. Now, this presupposes that Korle Bu is actually carrying a lot of the burden in terms of providing dialysis services. In fact, we do about 2,000 dialysis sessions every month. And how to sustain these services has been a major challenge. In fact, we are grateful for the partnership that we have with the First Sky Group, who single-handedly has sponsored dialysis patients throughout the last 6 or so years, and they're paying about 1 million cedis every quarter for that. So, in fact, if you come to Korle Bu, in terms of those who are actually paying, about 80% of our patients who are on our dialysis program, just about the number is around 250, don't pay anything at all because they are sponsored by the First Sky Group. The rest of the patients either pay out of pocket or are sponsored by organizations. So for a large majority of the Korle Bu patients, because we've had this strategic partnership with the First Sky Group, most of our patients do not have to pay any fees at all for dialysis. And so we are grateful to First Sky Group for this impactful intervention. But then, and this is just one organization that is trying to do that. And of course, over the course of time, inflation exchange rate issues have hit the cost of, in terms of the dialysis kits. So there was a need to do an upward review. Unfortunately, as you said, there was some administrative lapse. And so this was introduced prematurely when it shouldn't have been so. And so once it came to the attention of management, we immediately ordered for it to be withdrawn and for them to revert to the old charge. So we go through the process, to get the fees approved, and then the new fees can be applied. Now, if you take the fact that...
What that means is that, for clarity,
yeah,
we're definitely going to see an increase in the cost of dialysis at Korle Bu.
Yes, because if there was no justification for the increase, the proposal wouldn't have come in the first place. So there is a need to increase. As to what specific quantum the increase will be, it will only be determined after it has gone through the entire process, including Parliament, and then that can be...
I'll come back to you for a lot more, because obviously, as we know, I said this is a conversation we've been having, yes, but truly this really flew up the handles and hit the air. We'll come back to you. Right. I want to bring in my colleague, Kojo Yankson, right now, who's joining me, because Kojo, you have with you some dialysis patients who are on dialysis currently with you. They've been listening to the statistics and the breakdown of the challenge. Now with the picture we're getting of how many children are affected by this, with the example of Kolebu, I wonder if what we've heard reflects the reality that they've had to live on the daily basis.
Well, Evans, you've asked the question of the evening, and these are the faces and beating hearts behind the dialysis crisis. It's my pleasure to introduce you to Kojo Bafo Ahenkra. Now, Kojo has end-stage kidney failure, right? As he's sitting there right now, that's his current condition. He's been on treatment for 8 years. How he's afforded that? Well, he'll share the story with us. Thomas Vincent Khan, of course, we know of Thomas. He's been a kidney patient on dialysis for more than a decade. We have here those who are in the trenches providing the healthcare. James McKeon Amwa is a senior nursing officer at the renal dialysis unit of Kolebu. And of course, we have representing the Ghana Health Service, Dr. Fred Adumaku-Boateng. He's the regional director of health service at the Bono East region. So these are our panelists here in the Joy studio, and we can now start to understand the stories behind the big numbers that we've been discussing. I want to start with you, Kojo Bafo Ahenkra. First of all, help us understand what it means to have end-stage kidney failure and what you have to do to stay alive.
Thank you very much. End-stage kidney failure basically means your kidney is not able to function properly. It's not able to retract the excess water for you to give proper urine, filter the blood for you. So you need dialysis 3 times a week.
How much does it cost you?
Well, when I went to Kolebu 2015, it was up 2 point something before the first Sky group came in.
As in 200 and something?
Yes, I forgot the exact figure, but it was 2 point something. That was 2015. Yeah, but that's when I went there. That was it. But subsequently, as time goes, they've been increasing it until we got to the 380. But prior to that, the first Sky Group company has been in there supporting us. My brother, if not that, most of us will not be sitting here by now. So that has been what has been sustaining us up to now until 22nd May of this year, when the unit shut down to OPD. The unit was shut down to OPD patients because the consumables were short, so it was shut down to us. So we have to find our ways. Thank God, once again, there are a lot of private facilities around that have been taking care of us.
So do you have to pay for this private service?
Even in Kolebu, we are paying. The first guy is paying, so how much more private facility?
Right. So how much are you paying for private dialysis?
Currently, it's between 5 to 1,000 cedis, depending on where you go.
Every time?
Yeah, a session.
So how many sessions do you have a week?
Me, on my diagnosis, I'm supposed to do 3, but I don't have the means, so I do twice a week. Even twice a week, I'm not able to do it. I manage it. Sometimes I go for once a week.
Do you work?
Currently, I'm out of job.
How long have you been out of work?
For some time now.
Because of this condition?
Sure.
So how are you paying up to 1,000 cedis a pop, twice or 3 times a week?
Few friends, I have loved ones, and a particular sister I would not like to mention her name. Sometimes in what she eats, you put it down, but she can only pay once a week for you. The rest you have to few friends. And now we are becoming a burden to the society. You pick a phone, you want to call your friend. He knows you are coming to ask for money, so you will not even pick.
Wow.
You pick a phone, maybe you want to even to say hello, maybe there's an information you are trying to ask him. He will not even answer it. Later on, you call back and say, oh, child, I saw your call, now this Samuel. It's not true. Because he knows you are coming to ask money. And it's true. When you call the person, it's money you are going to ask the person. Because sometimes, maybe, for me, for instance, it's almost about a week, getting to a week that I have not gone for it. I'm just managing the situation. Somebody cannot even stay after 3-4 days. You eat, you drink. And then you could see sometimes you can't sleep at night, you can't breathe. When you lie down, you can't breathe. You have to sit down throughout the night. But if the money is there and you are doing 3 times regular, you see that you'll be fit, up and going and coming. So it's a very challenging issue.
Yeah.
Very challenging
I can picture the indignity of having to make these phone calls just, to stay alive.
Even the phone calls, I said they won't pick. They won't pick. They will not pick.
Yeah.
And it's like, eventually, you've turned a beggar. I mean, you've turned a beggar. And it's so embarrassing. You see your mates going, coming, you pick a phone, oh, Charlie, inside no good. Oh. So sometimes, like I keep saying, you wish one day you wake up and you are gone peacefully.
You have actually considered
why not
suicide?
Why not? Because you can't breathe, you can't do anything. Sometimes you become very weak, sick, and then you don't have the means. The only means for you to survive is to go through the dialysis, and you don't have the means to go. Kolebu is not a charity home. Like I always keep saying, the price that the new price that they brought, unless we don't want to speak to the truth, the reality on the ground is that it's factual. The price that they are charging now, the new price, is true. At least we are a bit educated. When you go through the net, you got to know the prices of the consumables. You could see the reality is there. I mean, that's how they are. I think it's supposed to be around 800 and something. But the point is, we cannot pay.
Thomas, I suspect you can relate to a lot of what we're hearing from Kojo, because you have been on dialysis for 10 years. 10 years. So tell me, I mean, is it really as we picture it? Is it a scramble between life and death from one session to the next, as you make phone calls and visit people, all in a bid to find the money to pay for your next treatment?
Yes, it has never been easy. Like he rightly said, there are times, I have sailed through the benevolence of people, classmates, family and friends, like family and friends, virtually. And I am always grateful to my classmates, my college mates. They've been very supportive. If not for them, I don't know where I would have been. I say a very good evening to
right. We have to work on your microphone. I understand that we have some challenges with your microphone. But I'm so glad that we also have with us James Amwa and Dr. Fred Adomako Boating, because you are the caregivers, if you will, the providers of this service, which now is in crisis due to the ballooning costs. So, look, how common is what happened to young Priscilla? The idea of someone who can't afford their next session, and so the next time you hear of them, they are dead.
Thank you, Kojo. I'm kind of a bit emotional because these are things we see all the time. Just this week, there was a 4-year-old child in Kolebu diagnosed of CKD and end stage. And I saw the mother, there's a little boy on oxygen. All the nurses there were even crying because couldn't see a 4-year-old child go through that. If you look at the cause of kidney disease, there are so many of them. Infections can cause that. So even for the children, simple malaria, if you don't manage it properly, can lead to kidney disease. So we see this all the time. And when Mr. Ankara is speaking, it's not all gloomy, because if patients are able to go through the care, we're able to manage them for them to be like Mr. Ankara. There are people who are working who are renal patients. There are pastors I know who go to church on Sundays to preach. They come for dialysis. There are ministers of state I know who are coming for dialysis and still go to parliament and do their work. So it's not like you get kidney disease and that's the end. But once you get regular dialysis, get your labs done all the time, be able to control your blood, make sure that your blood is up to a particular level, that's the HB. If you have hypertension and other comorbidities, you're able to go through the proper management. You can be like anybody else and do your work. But the major limitation for me on their side is financing. How are they able to afford? Even when First Car was paying for them, as you mentioned, there are people, some of our patients, who don't come because they'll tell you, I can't get money to pay transport from Adenta to Kolebu and back. Some of them come and we need to buy them food. So the challenges is not only about them, but other things that we need to have a conversation about. How do we even expand access to dialysis care to patients? How do we make sure that we do proper investment in dialysis care? In Kolebu, we used to have but now we have only 9 machines in Kolebu, 250 to 300 patients. We used to do 1,000 to 2,000 dialysis sessions in a week. We are not doing that anymore. So we really need to look at the conversation. I'm happy this conversation has come up. We've been seeing this in darkness, but now it's up. And we thank God it's happening, but we know we'll make it work.
4-year-old child.
4 years.
Just gasping for air.
And the youngest I've seen was a 3-year-old child in 2019.
Oh, no.
3-year-old child. So it's very common. We see them die. And people look at the numbers, mortality rate, but we see them as human beings who have died. It's so sad.
Well, one of these human beings who is kicking 10 years in, is Thomas Khan. I think we fixed your microphone now. So, Thomas, you were talking about how you're having to rely on the benevolence of friends and sometimes strangers. Tell me, do you have a family, a nuclear family? How is this affecting them?
Well, I think that it's been a drain on everybody because I keep telling people that this is one sickness that when you have it, it's not just physically draining, but psychologically and emotionally. Because when it becomes, when you are not well like that, it becomes a burden on everybody around you, even mere friends. Like they're also not happy, you being in that condition. So it becomes, that kind of burden to everybody, and it's been like that for the family as well. So it's not been easy, Kojo. It's never been easy.
Now, you told me that in the early days after your diagnosis, you had to be referred to a psychiatrist.
Yeah. Yes.
Why?
Yeah, I think that the doctor, and I remember Dr. Yawa Santiago. He referred me to see the psychologist because then, I was going through a lot psychologically, and there were times I really wanted to even give up.
When you say give up?
Give up, my senior brother said that there are times you want to end it all. You wish, you die peacefully and then everything ends. And then there were times it got to that stage. And, you get so confused and you're like, is it even worth it? Struggling and all of that. But, through it all, I went through the psychological therapy, and then that kind of even boosted my, energy. And because there were times I didn't even want to see my own picture. I couldn't look into the mirror because I had changed physically. Everything had changed. And, I kind of didn't like what I was seeing. The new me that I was seeing. It was really hard to, take it. I remember the early days when my friends and then through my media house, we tried to do some publicity to get some funds for me. Just seeing myself on TV with that kind of story, this is something that I've been doing for people, but, this is me and they are talking about me. It was kind of, there were times I didn't want to watch the TV or listen to the radio. Anytime they come on radio, I was kind of it scared me. I was like, wow, is this me? It wasn't easy to take.
Have you also seen an effect of this on your productivity?
Sorry, come again.
Your productivity, your ability to work.
It has affected because, one, the dialysis process itself takes 4 hours. You go to the hospital and the machines are not enough. So usually where I do mine, that is the Cape Coast Teaching Hospital, because we don't have a lot of the machines. I get to the hospital sometimes before 3:30 a.m. just to go and queue. If you don't go early, it means you are not going to leave there early. So you can imagine, even if we go and then this is a queue and he comes before me, he spends 4 hours. So it means that I will be sitting down waiting 4 hours before it gets to my turn. Then I also go on the machine for 4 hours. So virtually 8 hours is gone. So sometimes you finish and you are drained, you are tired. You get it. So thankfully my bosses understand me. So sometimes I get that flexibility to sometimes go to work and all.
You're one of the lucky ones. So far, the people I've spoken to, unfortunately, have ended up dropping out of work because it's just not tenable. I'm very glad Dr. Fred Adumakumbuating is here with us. And of course, you ply your trade in the Bono East region as the Director of Health Service. Let me ask you this. In the Ghana Health Service, is there a team that is working to solve the dialysis crisis?
So, thank you. I know the pain you are going through. To just sum up what our dear colleagues are going through, I'll just give bits and pieces of even literature that work has been done. And this was even done in Ghana. And I quote what they said. So that, and I believe this is a dialogue context where we really want to look at a long-term solution, and not really about piecemeal in addressing. Basically, what we are seeing is a sign and symptom of a bigger underlying problem. But until we fix that, if there is a tap you open and water is coming out, you cannot really handle it unless you close the tap. But let me quote what was written in this literature. The management of this condition is highly burdensome, as it takes a heavy toll on both the financial and emotional well-being of both patients and the loved ones. We can just see what they have just described. And he went on to say that in the sub-Saharan Africa, the outcome of end-stage kidney disease is rather poor, because the resources and the expertise needed for combating the disease are scarce, and there is limited awareness of the disease and its risk factors. And this was done by Autry and Etar, BMC 2020. I just want to give you some statistics when it comes to Ghana Health Service, the country, so that we can juxtapose these cases that we are seeing and then know that what we are talking about is at the tip of the iceberg. All the work that people really have done was more in the hospital, who really have the problem. But if you go to the base, there are challenges. Let me give some statistics. If you look at our statistics for kidney-related diseases, and this was from DIMS, 2019, we had 19,230 cases. 2020, we had 23,000. 2021, 31,908. Then when we come to 2022, 32,382. You can see what is happening. And you can see it's mimicking what is presenting. Let me talk about the three common causes of what we are discussing. And if you look at the literature, it's the same. If you look at the United States of America, the leading cause of end-stage kidney disease is diabetes. But when we come to Ghana, hypertension is the leading cause, and the other infections. I want to put this in context so that we can have a bigger discussion. Now, if you look at hypertension, 2019, these are cases that we have not even diagnosed of, even the spectrum that we are talking about. We had 626,366 hypertension. 2020, we had 59,630. And then 2021, we had 61,010. And 2022, we had 622,900 hypertension, which is the leading cause of why we are here. Then if you take diabetes, 2019, we had 178,36. 2020, we had 174,202. 2021, we had 203,054. And 2022, you can see something is happening. And unless we come together to look at this, how are we going to address? I'll give you some statistics of where we have dialysis in the service and the focus of dialysis. One of the major things that we are talking about, basically we are now discussing about chronic stage. Look, but we have a lot of stages or spectrum which can even be addressed by this dialysis. Mm-hmm. So that of necessity, what we are here is even the last stage that we should be talking about when it comes to dialysis. You need dialysis for a lot of acute cases that people come, which you can actually do something so that people don't progress. Mm-hmm. And it's important that our attention will go there so that the people truly who are supposed to have end-stage chronic renal failure, then we can manage them. Because if we don't close that, and all these numbers, one, are not picked in early, two, are not managed very well, and three, are not even taught how to diagnose this, even from the lower basis to be referred to where we have these nephrologists, then we have a lot of issue on our hand. So this is the context. Eastern region is having dialysis, but when you go to the regional hospital, when you go, it's mainly used for acute kidney injury. You have the former regional hospital, which is now the teaching hospital. They also have dialysis. You go to Tamale Teaching Hospital, they have. Efia Kwanta in Western region is having. And then you have Upper West. They are also having 2. So these are the distribution in terms of.
If I may, I mean, you've shared a lot of important statistics, which means that the Ghana Health Service knows the size of the problem. I'm interested in the solutions you have implemented, right? Because you seem to even know how it should be addressed, that you should tackle the acute cases. Once you've dealt with them, then all you have to do is focus on the chronic cases like our guests in the studio. Now, my question is this: if you know the size of the problem, what have you done to fix it? You know how many people are coming from hypertension, how many people are coming from diabetes. What have you done?
Okay. So, and this is a major policy issue. If you look at the National Health Policy, one of the key things that is there in the policy is workplace infirmaries. And by means of workplace infirmaries, all places that you have people working, even marketplace is part of them, school infirmaries. If you come to Bunei, we have what we call wellness clinic. And the wellness clinic is a clinic that anybody can walk in and have your BP checked and have your sugar checked. That is one major thing the service is doing. And that you don't have to be sick to go to the hospital. And then we have other pharmacies that are also checking. In Bunei, we have what we call the Wellness Day. Every last Friday of every month, we have made so noise about it that, look, if you have not checked your BP, then on your birthday, kindly check. So we have what we call the Wellness Clinic. If you go to any Ghana Health Service facility, you can go in and ask about the Wellness Clinic.
But in spite of that, the numbers are rising. So it's not working, is it?
There are 2 issues that we can look. You know, there's always darkness before light. And the moment you begin to look, look, all these cases that we are talking about, like it never existed. They have been there until a torchlight was shown on. So until
you
begin,
knew. You knew.
And
Ghana Health Service was aware.
Obviously. Yeah. And this is what we are doing. So we want to pick as early as possible. And the best solution in the States, I even wanted to add a quote, and I'll come back to what Ghana Health Service is doing. He said, look, and this was done by a lady written by Tamara E. Holmes, publishing. The bottom line, dialysis can be costly even if you have health insurance. Look, the quality of life, no, we shouldn't even get there. What should we do? Pick them as early as possible, one, which we are doing. We are doing a lot of massive screening with support from PAF and other people. We are doing massive screening, that is one. 2, there is a need for all of us to be educated that when we pick hypertension, it's not a license. If you look at the statistics, most of the people at end stage adult are males. Yeah. And because the males are health-seeking pattern, a behavior is very different from the others. I don't know about the statistics, but you see that we are the culprit. How do we also engage all sociologists, anthropologists for us to know that, look, hypertension, diabetes, the earlier you pick them and even go on medication, is better.
But because you haven't engaged these people. You're making it like a suggestion to
No, we are engaging them seriously.
When? Which team is doing this? Give us the names of the people leading this project. How far along are they? What progress have they made? What numbers have we seen as a result of the work they are doing? What are you doing?
Okay, so when we come to the service, we have what we call the Health Promotion Unit. And the basis for the health promotion to really talk a lot about the causes. And I believe that we talk about whether we have to capture it, we can capture it. But the simple example I'm giving you, if you come to Bunei, it's another facility. Every Friday, everybody entering the hospital, we check your BP. Once we check your BP and put you on medication, hardly would we come to this stage.
But why only Bunei East? Why is this not a policy across the Ghana Health Service?
Across the whole Ghana Health Service.
When I go to hospital, that doesn't happen to me.
Are you sure?
I'm positive about it. Nobody has said, come here, let me check if you have kidney problems.
No,
when
okay.
I enter the
so there are 2 ways that we have to look at it. You have to look at the BP. In fact, kidney problem.
Let's double check. These are 2 people who go to the hospital every week. Is that your experience in the outpatients? Do people come along and say, we want to test you for hypertension or diabetes or kidney disease?
Well, it's not something that I don't think it happens where I go, unless you yourself go there that I want to be checked.
What about you, Kojo?
I can't attest to that because first, where we used to do the dialysis up there, we are not privy to what's happening at the OPDs. And currently, where we do our dialysis, where it is close to the OPD, we don't see. We are a bit out of, not out of Kolebu, within Kolebu, we are far away from.
Well, James works there.
I was just going to say that kidney disease is a non-communicable disease. So when we have the conversation, let's also look at the fact that non-communicable disease now is rising globally. And so when it comes to lifestyle issues, there are major risk factors for all of these. So he mentioned hypertension, diabetes, and other causes. If you have a population where we don't exercise, we'll have this non-communicable disease increase. We have a population where people don't eat well, people drink alcohol, people abuse their system, they don't rest, there's no stress relieving activity they can do to reduce their stress. These need to go up. Now, kidney disease on the rise, I'm talking about it. Diabetes is rising, cancers are rising. So we need to also look at the conversation about how do we really work on bringing policies that will help protect our people from non-communicable disease. And one of them that I want to share with you, when we did the sugar sweetened beverage tax I spoke to you about some time past, ultra-processed foods, these soft drinks, these cookies and others that are just rich in glucose, some high salt, and all of those things, will lead to obesity, diabetes, and lead to chronic disease and other diseases. There's a policy now that says that we are putting a 20% tax on it, which will make it more expensive, which will reduce consumption, which will raise money for government to do other interventions. And one thing I was going to say that those money that we get from this should be channeled into management of non-communicable disease like this disease, so that if we need to do research, look at what is the local causes of CKD in our country, we can look at all of this. What he mentioned, it may work in Ghana Health Service. Kolebu is not under Ghana Health Service, so that particular wellness clinic may not be there, I'm not very sure. But if he says it's working in Ghana Health Service, maybe it is, I can't verify it.
Well, I mean, he's been able to tell us what they are doing in Bono East, which is good. The question is that who is planning this on a national level? Evans, that takes us all the way back to policy. And of course, you've got the right people in the studio with you to have that discussion, don't you?
And indeed, Kojo, thank you very much. And that conversation is pretty riveting, hearing from the patients themselves. And joining me in the studio, and there's a lot of questions around policy intervention to try and deal with this particular challenge. With me in the studio is a presidential advisor on health. And so I'm going to bring him into the conversation. Obviously, Perpetual is still with me, with the Ghana Registered Nurses Association, Dr. Ampoma himself with the Kolebu Teaching Hospital. On Zoom, as you may have noticed, we have the Dr. Kwame Safansedu with us also. I want to bring you in, Mr. Siasari. So you've had the conversation. From the patient's point of view, the cost element is key, right? And for them, that is an issue, a barrier that needs to be removed in dealing with this whole crisis. First of all, you agree this is a crisis that needs urgent addressing. And from what we were hearing from the Ghana Health Service rep, there's an appreciation of the problem, but the issue really is about finding the solution to it.
Yeah, thank you very much, Evans. I've been listening to all the speakers, especially the patients and Dr. Adumako from Ghana Health Service. You see, end-stage renal diseases is one of the non-communicable diseases, as the other gentleman said, that is causing a lot of problems, not only in Ghana, but worldwide. Because people have changed their lifestyles. People are growing older and all sorts of things. So if you add all together and you don't prevent and early diagnose these diseases, you end up having end-stage renal disease. And that is where the problem is. And once you end up as end-stage renal disease, then you need treatment. And I've realized that we are just talking about dialysis. But the definitive treatment for end-stage renal disease is a renal transplant.
Yeah, but what you say is a function of policy.
Yes, the policy.
You are the presidential advisor.
Yeah, the policy is.
So what advice have you given the president on this?
Yeah, the policy is that if you look at the policy document of this present government, we have what we call, what Dr. Admako was describing, that everybody in this country, as much as possible, should be able, if for nothing at all, during your birthday, walk to a clinic or a hospital or even a health center or a teaching hospital and then said, I'm coming to check myself. You are not sick. That is what Dr. Admako was describing. And I can assure you that it has been institutionalized in Ghana Health Service, because I've been in Ghana Health Service before. There's a health prevention unit in Ghana Health Service. If you go to Dodowa Hospital, I'll give that example. There's a whole unit for wellness clinic. So wellness clinic is a policy document, a policy directive in all the health sector, from the chief center right down to the teaching hospital.
Then there must certainly be a disconnect between what the hospitals are supposed to do and what the community actually feels must be done.
I'm coming there. You see, that's one of the things that you are saying here.
But it's also policy effective.
Yeah, to make the policy effective, the media, have to carry this to the people.
Yeah, but
I'm happy that you're having this discussion.
Yeah, but then you have to admit that once you design policy, not for the sake of it, the policy has to be implemented.
The policy has been
There's definitely a missing link there and possibly a failure that is leading to
the
this.
missing link is very easy to solve. The missing link is you use the media, you use the community, you use everybody to propagate. For example, our brothers in the diaspora, when they come here, they will tell you, oh, I have to rush back because I'm going to do my medicals. It's not sick. But in this country, people wait until they are sick, sometimes wait until they are carried to the hospital, and then they are told that gone so soon, or you have a renal failure that you need a dialysis. You have ended it. But if you start early, I will say that I call it adult weighing. When you put in the policy document, I say it's called adult weighing. Children are not sick when they go for weighing, isn't it? Yeah. You carry the child, you know that every 2 weeks or every first 6 weeks, you have to take the child to this. So at least once in a year, we the doctors we are cooperating to it, with nurses. We don't do it. Once a year, just walk to the wellness clinic, sit down, you'll be weighed, your height will be taken, they do your BMI, they check your BP, blood pressure to see if you have a high blood pressure. They will check also your urine, simple test. And if you're a woman, they will check your breast and maybe your womb, the cervix. And if you're a man above 50, they check if you are urinating well. Once you do that, you get to know whatever is going to happen to you and all these diseases early enough to be treated. Because there are two types. You can have an acute kidney problem, and then if you don't treat it, you go into chronic kidney problem. And that's where you have a problem. Once you read there, either you like it or not, you have to purify your system. And it's through, one of the ways is through the kidneys. And luckily, there are 2 kidneys everybody has. So everybody has one spare kidney that maybe you can give to another person. And that also comes with a policy statement. We are now trying as a much...
So what is the policy statement on that?
The policy is that we are now doing kidney transplants, for example, in Korle Bu, but we should have a law backing the donation, the storage, and then also giving the kidney to...
I take note that they use the word should.
They should, yes.
We must have, and
we must have.
Why don't we have it?
We are working on that. I know that there's a document which is being looked at the moment. I remember when I was in Ghana Health Service, we set up a committee. We wrote a document as far back as 2018, which we presented, and that's what we are making.
Has Cabinet approved it?
That's what we are making sure that it goes to Parliament. It's Parliament.
Cabinet will approve it.
The Cabinet approve it, goes to Cabinet. We will make sure that it's done. But what I will say is that for the wellness clinic, it's a policy directive which has been given to Ghana Health Service and all the agencies of the Ghana Health.
I'm interested in the policy, the law bit. What's the timeline? When do you hope to hit Parliament for that process to start?
I know the Ghana Kidney Association, the Ghana Ophthalmology Association of Ghana, the Fertility Group in Obstetrics and Gynecology are all now advocating, and the plastic surgeons. And I'm a very strong advocate for it. Because plastic surgery is talking about plastic surgery. When somebody has burns, you can also have a skin transplant, a tissue transplant. For example, a lot of people are blind because of cornea scarring. And we do cornea transplant here, and people see again. So these are things that we have to, as quickly as possible, make sure, and where I said we'll make sure that it comes through Cabinet, the Minister brings it to a Cabinet.
Any timeline? Timelines, because people, this is a matter of life and death.
We are working on it.
Okay.
I won't tell you, if I tell you by the end of the year, you come and ask him why it hasn't been done, but it has to go through a whole process.
Yeah. Stay with me.
But for the wellness clinic, it's a policy. And today, I'm telling every Ghanaian, you don't have to be sick before you go to hospital. Walk to the hospital on the week, the month, or the day of your birthday before you come and chill. Just walk to the hospital, or after chilling, walk to the hospital, go and check yourself. Check your weight, check your height, check your parameters, blood pressure, and everything. And then you will know if you are sick, especially for kidney disease, early enough to solve it so that you don't reach the end stage kidney.
And then stay with me, and Dr. I'll come to you also, Petrol. But I want to quickly go to the man we started with, and that's Kwame Sapansudu. Kwame, you've heard the policy makers, at least you've heard the President's Special Advisor, you've heard the Ghana Health Service rep. Are you convinced that our policymakers fully appreciate the gravity of what we are talking about?
Thanks, Evans. You know that with me, I always try to back anything I say with numbers. I started the introduction with speaking to Ghana's outpatient per capita, which is 1.06. It actually rose to 1.13 in 2021, and it dropped to 1.06. And this is in the holistic assessment of the health system's program of works. It's a document that is written by government. If you go into that document, outpatient per capita was 0.98 in the year 2000. It's 1.06 in 2022, or sorry, in 2021, which was the last document they were discussing. Dr. Isiasari talks about a government policy, which obviously has been implemented from 2017, where people have to go to these clinics and see a clinician and get their, blood pressure measured, their sugars checked, their breast checked, and all that. The first thing we would have seen is an uptick in our outpatient per capita, because they'll first have to be booked in as an outpatient. In the year 2017, and I'm quoting government statistics, our outpatient per capita was 0.99. It's now 1.06. After implementing a policy for 7 years, 6.5 years to be fair. And you ask me, Evans, that on the basis of these numbers, which are Ghana Health Service numbers, which they held a conference on last year, I would be conversant and happy with what Dr. Adumako, who is my friend, and Dr. Isiasari, who is my father, virtually, have said. No, I am not. And it's not because, so it's either there is a policy breakdown, the policy exists, but the implementation has not turned around into health outputs, so that you get the health outcomes, which is a decline in the number of people. If you listen to Dr. Adumako, the numbers he's putting out are scary. And if we are getting these upticks and our outpatient per capita is virtually stagnating, and the policy has been implemented for 6.5 years, then obviously the statistics do not support what Dr. Isiasari has said. And he has those documents because they put them out. So if I am wrong, he can speak to the document.
Professor Dr. Isiasari, you want to address that quickly? Because there are questions for you from some of the patients.
Yeah, unfortunately, I didn't bring the statistics here. But maybe Dr. Adumako can assist us because he is a regional director. But I believe if you look at even the number of diabetes and hypertension that Dr. Adumako has given, I don't know where he's coming from, but in 2019, he said the hypertension was 19,000, 23,000 in 2020, 31,900 in 2021, 32,000 in 2022. And the same thing is also for diabetes, which means we should ask ourselves a question. Were these diagnoses done as part of the wellness clinic or not? He is talking the global issue of per capita OPD attendance. And you should also know that between 2019 and the 2020-2021, because of COVID, OPD attendance apparently came down. So it also has an effect. But the question I ask Dr. Siedu, my nephew, is that he should also tell us, he should also averse himself to the point that these increases in diabetes and hypertension that you are seeing, They are all maybe patients some of the patients who went for normal checks. But as I said, it's not every hospital or every clinic or every health center which has set up the wellness clinic. That's what we are encouraging Ghana Health Service to set up. And it's not all Ghanaians who are availing themselves now to the wellness clinic attendance or what I call adult way. We've been speaking about it, we've been telling people, and I think it should be a campaign by all of us that let us look at ourselves, and especially employers. I believe that when you want to promote anybody, you should first ask, have you gone for medical check? And it should be something that should be done in every workplace. You can call even the hospitals that you work with that come to our maybe Joy, and then come and do a checkup for all our employees here. It should be done. And these are the ways that we can do to at least early diagnose all these diseases. But more importantly is prevention and lifestyle changes that we are having. We have to try as much as possible to prevent these things. And there are ways we can prevent them. We all know. Don't eat too much sugar, do a lot of exercise, walk around, and don't live a sedentary life and all sorts of things. So it's an individual, see, health is the responsibility of the policymakers and then whoever is in charge, and as well as the responsibility of you, the individual. And it's all we need to be talking and let people do the uptake of health services in our society. And it comes with education.
Yes, and partly, and you notice that we've spent a chunk of the conversation so far on the preventive, which is important. And I want to bring in Kojo. Kojo, Kojo, your panelists there, the patients, they have a question for Dr. Nsiasare.
The renal patients in my studio have some questions for the policymakers in your studio, Evans. We're going to start with you, Thomas Khan. You have been a renal patient on dialysis for 10 years. What's your question?
Well, Kojo, I think that listening to Dr. Nsiasare, he's been talking about policy documents. And I want to know, we are dwelling on dialysis, all right, but the end result or the long-term solution is the transplant. I want to know from Dr. Nsiasare, what is the policy direction? What have we done as a country in terms of organ donation? Because it is one area that we've not really taken our minds to. And this is one thing that in our part of the world, people do not really know about it. People link it to superstition, all sort of things. Meanwhile, people could just be donating their organs just to save lives. Because, could you mind you, or maybe people do not know, there are people who are born with just one kidney. People are not aware. That is why sometimes when they call for health screenings, we have to go. Because I remember we went for one event at UCC, and one student just came and told us that he didn't know he had one kidney. So all this while he was just walking.
So your question is about organ donation. What is the policy here in Ghana? Is there a policy document? Do we have an organ bank, for example?
Yes.
Yes.
Do we have laws that can even
govern organ donation? Thank you for that. Kojo, what's your question?
My question goes to Kolebu CEO, Mr. Dr. Poku. When is the cabin going to be open to the OPD patient? We are dying. People are dying outside there. Just Sunday, we lost another patient. So if now they say the thing has been reduced to the old price, whilst we are waiting for the new price to be approved by Parliament. Parliament is on recess. We don't know when they are coming back. So are they trying to say until they come back before the new price before we come out? We want to know. We beg them.
Two important questions for your guests, Evans.
And I'll take Dr. Mpoma first to that last question.
All right. Okay, so thank you very much. I think this is an important conversation, like I said, and we are very sympathetic to the plight of the dialysis patients. Now, just to also give you some numbers. We've been under recovering for some time now. As I said, our prices were set about 3 years ago. So this, and you should also appreciate where we've come from. When dialysis started in Kolebu, the average cost per session was around about $100 per session, equivalent of $100. And now the price has come down considerably. As of today, but the current, we are under recovering for the current price. And so we also need to, much as we sympathize with the patients, we also need to keep the service sustainable. And so First Sky support has been very, very tremendous in helping us to be able to provide service for about 80%, free dialysis for 80% of the patients that we treat. Unfortunately, because of the increase in the cost of the consumables, not the increase in the cost as such, because in Forex it's the same, but when it comes to the CD equivalent, it's gone up. So we need to, make those adjustments. And so that is so. In fact, as we stand now, the renal unit has a deficit or has a financial deficit of 4 million cedis that we need to, that we are trying to find ways of.
Is that debt?
Yes, that's
or you
the debt.
owe a supplier?
No, it's debt. Yes, debt that we owe.
How do you accrue that? How was that accrued?
It's because of the under recovery from the service that we are providing, and so to continue to run at full throttle would mean that with this debt is going to balloon. Okay, and that is why there was a need for us to look at adjusting the price, whilst we also engage with the next relevant stakeholders to see how best this deficit can be met. In fact, somebody mentioned the fact about the nurse talk about the machines. I
think you have 9, it says.
Yes, in fact, we had about 13.
But now, how many do you have?
No, we had about 15, but now I think they're about 12 or so functional. But then we also have about 45 machines that the supplier or the supplier is supposed to bring in, to show up our services. That have been withheld because of this debt,
Who is withholding it?
That's the Fresenius Medical Care. That's the company that produces the dialysis machines and supplies the consumables.
To Kolebu Teaching Hospital.
Yes,
you have a contract with them?
Yes, please.
Okay. Well, what is the arrangement with them exactly? So they supply, and then how do they make their money? You pay them?
Yes, so we pay. Yes, so we pay. Yes, so the suppliers, and then we pay them. But then we have to pay them in euros. And so you can imagine what happens that you accumulate. You're taking money in cities, and you accumulate. The money to transfer. But then as you accumulate, like last year, for example, when there was that sharp, change in exchange rate, that means that by the time you are ready to transfer, the CD has actually lost a lot of value. So those are some of the challenges that we've had, and we are in negotiations trying to see with them if we can actually, do a certain benchmarking on the price for, let's say every year or every half year, so that we are not subject to those. We reduce our exposure to that kind of fluctuation.
So what is this now? They've withheld the export of those materials into Ghana.
No, we've been able to secure some of the consumer. In fact, the decision to reduce our out was that we're running low on consumables, and because of the debt, the outstanding debt, the supply had been withheld, and so we managed to find some money to pay them, to pay something which enabled them to release more consumables to us. In fact, it was during that period that the outpatient services was restricted.
And the question that was asked directly was, when will you open it?
Exactly. So we are now engaged with government, with the ministry, with other stakeholders to see how quickly we can, find the resources to advance. Because at the moment we are sitting in a 4 million city hole, and so and every session of dialysis that we do, because if you look at the current, if we are to operate at our current capacity, which is about 2,000 dialysis sessions every month, then it means that we are going to accumulate about 961,000 cedis of debt every month, in addition to the 4 million cedis that we have already. So this is financially unsustainable, and that is why we are also in discussion to see how this can be ameliorated.
Okay, so that's back to the question: when will you open?
We are hoping to get a breakthrough in terms of getting some advancement in terms of funds, so that once that is secured, then we can be able to open the service out fully. But as I said, we are still open for emergency. So if any patient, the situation becomes critical and it's an emergency, we are still open to treat those. We are still treating emergencies.
So for clarity, as we speak tonight, you can't tell when exactly the OPD will be opened.
Yes, exactly.
You can't tell.
I can't. Yes.
Okay. And then fundamentally, because you don't have consumables, enough consumables.
No, we have the consumables. Don't get me wrong.
Okay.
We've secured the consumables, but if we deploy the consumables now at the current rate, we are under recovering. So
and raise the funds to pay
Exactly. Okay. So then we'll still, it will become a vicious cycle. Then in the end, we may not even be able to do the emergencies and the inpatients. And so at the moment, we are providing the service at the old price for inpatients and for anyone who comes in as an emergency. So that safety basket is there. But then for us to be able to roll out to go back to our maximum output, we'll need to be able to find a way of recovering. Otherwise means we are going to end up in a deeper financial hole.
We'll come back to the tax question because it's very, very important, has come up. But Dr. Siansari, before we even answer that question,
may I add? Okay. Because I think one of the issues that came
I'll give you time, okay. I promise you, okay. All right. when we come back so you can address that in full, because you've made a very important point. You say you're working with government to help you in this particular, the issue you have now.
But I was actually, there's something to do with I'm interested in solutions.
Yeah, we'll come to that. Trust me, I mean, we'll come to that. But because you have Siansari here, okay. Directly, he says they need your help to get this particular challenge with the financing sorted. When is government going to give that help? And in what form will they get it?
Yes, first and foremost, what I would say is that there's a tax exemption regime. So you're going to taxes. You see, one of the issues we have to get a solution to the whole issue.
If you can address this specifically for me, I'll be very grateful. The question about government, they need help now.
Yes, I saw him.
So they can open the OPD.
I saw him yesterday of his board chair at the presidency. So the help is being sorted out. And they will get the help as quickly as possible.
Okay, so what help exactly do you need? Do you need the government to give you tax relief, or you need them to give you money? Let's drill down. What do you need?
That's what I wanted to answer the tax. There's a tax exemption.
Forgive me, I think he has an answer. What exactly do you need? Because the conversation we are having is solutions, right? And this is a very important part for those who need that treatment. So what exactly do you need?
Yeah, so immediately an injection of capital to help us clear the outstanding debt would immediately free us up.
So government should give you money.
Yes, exactly. And
4 million or more.
Yes, please. And then we also need to look at the long-term solution in terms of the current pricing, because if we do not also look at the pricing, that means we'll find ourselves back in this situation a few
when you say pricing, you want government to bear part of the cost?
That is a solution that we all have to look at. Whether we are going to increase our contributions to health insurance, that's an option. Because if you look at the health insurance contributions, for instance, we are paying very little. I mean, somebody who earns maybe 10,000 a month, how much health insurance premium do they pay in a year? Just about maybe 100 and something cedis. It's something very paltry. But then if all the advanced economies that we've gone to, you find out that when you get your paycheck, maybe about 5% of your salary goes into national health contributions. And now that we have everybody has a Ghana card, we can identify most individuals within the country. We can track payments of this insurance premium. So then we are, and then I think that we can also make sure that these monies go directly into the health insurance kitty, so that it doesn't have to go through a circuitous route, so that it's all available for the health insurance to be able to deploy in terms of the health of people. So today is dialysis, tomorrow to something else. So that we can look at the basket of conditions that affect Ghanaians, because all these people are Ghanaians, and as I've always been saying, is that the quality of every society is determined by how how we treat the
most
vulnerable. Exactly.
The most vulnerable, yes.
So that is what we are looking at. So I think that if we're able to do something like that, immediately to free up a lot of resources so that health insurance can become meaningful. Because you see, you do not. Personally, my feeling is that you don't need insurance for something like malaria, because malaria treatment has come down so much that the average person or even the poor person can afford, to treat malaria. But then if you have a road traffic accident, if you have, pregnancy complications,
or a kidney,
you have dialysis, a kidney failure, you would need support. No matter how, if you're a middle class person, it is a big drain.
So I hear you say the NHIS must cover this.
I'm not saying it's covered, but I'm saying that we must, NHS could potentially cover this, but we must also look at the contributions that we are making into the NHS.
Because then if you increase the contribution, you get more money.
Exactly.
So then subsidize.
Subsidize. Because at the moment, we are looking about 700
cover people completely.
Between 700,000 people, all right? And we did the math and realized that, look, you need And let's say if the number is about 1,000, you need about 3.4 million cedis every month to cover all those people in terms of their dialysis needs. So that works about 36 million cedis a year for dialysis. So that is a potential solution that we can be able to find if we're able to increase the contributions that we are making to NHIS. The other issue that we have to look at is also the organ transplantation, because dialysis is actually
organ transportation.
Yes, sorry, organ transplantation. Yes.
Transplantation.
Yes. So that in this particular situation, it is kidney transplant, because no matter how good the dialysis machine is, it can never be substitute for a kidney. And so that is something that is the only way that people can exit from being hooked on dialysis for the rest of their lives. And so that is, in fact, that's why what we did as a teaching hospital was to build capacity so that now our local surgeons are able to carry out transplants on their own. In fact, next month we are going to have the next session of transplantation. And that's why we also started canvassing the issue of, in fact, your colleagues were there to support us, to start canvassing the issue of having a national policy on organ transplantation in general, so that it covers both kidney and liver, eye, skin, all those.
And you make an important point. It goes to the first question. Yeah. And I want to put that to Dr. Nsiah-Asare. Doc, but before that, though, you said they will get the money because they've met the president.
Yes, there's discussion going on.
So they will get the money. You can assure, because everybody's listening. This is very, very important.
Yes, they have to be supported for Ghanaians to get the treatment.
So you can assure us today on the show that Kolebu will get the money to open the OPD.
Kolebu's chief executive was at the presidency yesterday of the board chairman. So
I just want to get a commitment. They will get the money.
Oh, the government is to assist and help the people. So whatever government wants to do to assist the people, that's what
they will do. Then let's go to the question that was asked of you.
The question which was asked was, what are we doing about organ donation?
Yes. If we can do it very briefly so I could.
Yes, as I said, there's a document which is being reviewed so that we have a law. It's very, very important. It has to go through cabinet for cabinet approval and then move to parliament for parliamentary approval, and the president will assent to it, so that we can harvest the organ, we can store the organ, and also donate the organ. It's not only for kidney, because even for the in vitro fertilization that they are doing, it's a tissue. Skin from other person to another person is a tissue. So all these things should be backed by law. And that is what is going on. And as I said, I'm very key. He is very key. Everybody is key. The Ghana Kidney Association, the Ghana Ophthalmological Association, and then even the Plastic Surgery Association and the IVF team are all on us. And some of us have taken up as our, because I'm a doctor, first and foremost, that this thing should be done and done as quickly as possible. And then, as he rightly, as the Dr. Ampuma said also, we are building the capacity of our surgeons. Actually, kidney transplant is one of the most not so complicated things that we can do, as any surgeon can do. And we know that there's also a urology unit which is almost completed at Kolebu. It will be part of the place where we can have also renal transplant done, and to train our doctors and our nurses and all the health workers to go into that type of field. I know Konfonoche also is trying to do the same thing. So if you have about 3 or 4 transplant centers across the country, and you have where the organ is, and the people should also know how to donate parts of their bodies. As one of the patients said, everybody has 2 kidneys. And normally we need about 1 kidney to carry out all that. So you can easily donate. And the most important thing to me is the eye. When anybody is about to die and your eye is good, you can remove your eye and then donate your cornea to somebody. After all, when you die, you close your eyes. So when the eye is not there, nobody will even notice it. And these are things that, as a country, moving forward in our health systems, we can do in this country. And even Ghana then will become a medical tourist center where 380 million people in the West Africa sub-region.
Many will say you're looking too far ahead.
People, no, we are not.
Problems need to be, you have to solve the basic ones
we
first.
Solve the problem, and we solve the problem in such a way that we can also solve even every other problem. And one of the most important things is that even before we go to all these things, I am also challenging Kolebu, Konfonoche, anybody who has a renal dialysis, to have bulk procurement. So if they all join together, when you buy it in bulk, you get the prices down. I remember I used to do it with my senior brother from Pomboatin when we were in Kolebu. We were buying some drugs bulk, and it was very cheap and affordable to the people. So that's what we also are telling them to do. And the most important thing is that our pharmaceutical companies in Ghana and the new ones which are coming up should go into manufacturing of the consumables, especially.
There was a story today that talked about that.
I remember very well that at the World Health Summit, I think 2019, B. Brown in Germany said they want to build a center like that in West Africa, and they thought Ghana is a place to go. But then COVID came, and everybody went.
Doc, stay with me, Perpetual. Listen, I want to hear Perpetual on the talk about the proposed solutions and the questions you've had so far. And you are on the ground, right? All the things you've heard about the policies that we're told are being implemented, that we all now have talked about in terms of its ability to actually lead to outcomes, right? Give us your sense of, I want to hear the reality. You've heard the Ghana Health Service policy, you've heard the talk about what Kolebu has proposed and what the Dr. Cesare says they are doing. Does that reflect in what you see on a daily basis across the country from the perspective of the registered nurses and midwives in reality?
Well, indeed, there are these wellness centers, but it comes back to the health-seeking behaviors of our people, we ourselves. And it's important that we recognize that we are in a country where when people are not well, the first point of contact is to go into a chemical shop or a pharmacy and get some medications and start treating themselves. When they can't handle it anymore, that is when they go to the hospital. So a lot of people do self-treatment and will hardly go to the hospital. From the data that shared,
with the Kidney Association of Ghana,
how many people visit the hospital in a year? We don't do that often, but it's important that we use all the channels that we have to educate the population. As much as the policy is being drafted or being developed, as much as arrangements are being made to offset the bills of Kolebu and make the system run efficiently for patients, it's important that at the center of it all is the Ghanaian who needs medical help, who needs dialysis, who needs some immediate treatment to resolve the conditions that they are facing. And it's important that we look at it holistically. Immediately, I think that we should be able to look at the National Health Insurance Scheme and find support for the patients who are going through all of this. Yes, it's the end stage. There's a spectrum of the whole kidney disease process. And if we take it from the beginning till the end, there are a whole lot of things that we can do. From the beginning, I said health-seeking behaviors. Let's begin to take our health seriously. Let's visit any chemical shop or any pharmacy to check our BPs, our blood sugar. Visit the established wellness centers that may be in existence in some facilities, because indeed, they are not everywhere. It's not everywhere. And you will not be able to access, that kind of help or health care that you need from those angles. But it's also important that we look at our lifestyles. There is need for lifestyle modification. Non-communicable diseases, diabetes, hypertension, are all as a result of lifestyle. We are becoming more westernized in terms of what we eat and everything that we do. Let's move back to our locals and eat our local foods that are nutritious and give us good health. And all those lifestyle changes can help us. Let's not go about just buying any drugs from just anywhere. Let's go to the right sources to get medications to resolve our problem, because we have fake medications out there, and we have medications that are also having just a small element of what it's supposed to cure. Let's use the media. You guys are fantastic. Let's propagate the news of how we need to take care of our health. If you have been diagnosed as a hypertensive patient, a diabetes patient, you have your regular drugs that you are supposed to take. Take them. Regular basis. Forget about the fact that it will have these side effects on you, these adverse effects. You can always have a conversation with your GP to have some of those things corrected. So take your medications seriously, and let's begin to have a reduction in the numbers of these conditions. Because, like I said, majority of Ghanaians are in the lower belt of the economic ladder, and therefore we don't have the money to actually pay. Even if you take it to 100 cities, people will still have difficulty in paying for it. So it's important that we focus on the preventive measures, which is very important.
Doctor, I'll come to you because you're a man who used to work at Kolebu joins us now. He's Dr. Titus Bayo. About the prevention is very, very important, and that's why we've been emphasizing on that. But we've heard tonight that at Konfanochi alone, between 25 and 40 children die there a year, right? The children, it's not about lifestyle, is it? I mean, they're not drinking, certainly. It's not about they're not doing the things that we do.
Yes.
That we're talking about in terms of the prevention, and so I want to take that there because Dr. Titus Bayo, if you expand the conversation beyond the prevention, when we've talked a lot about that, for us who are grown-ups, we need to do that, right? And that is very important. Doesn't this conversation also boil down really to making the dialysis treatment free, bottom line? Isn't that simple as it is?
Evans, thank you very
Nationwide,
much
beyond
for the opportunity. Yeah, thank you very much for the opportunity. And let me just greet your the co-panelists. I would agree with you perfectly that this is one of the things that we have established this evening that individuals cannot do for themselves. And what a person cannot do for themselves in functioning states, the state must take it up and do it for the individuals. In fact, in all our discussions, one population or one segment of the population that has been left out are my patients, the pregnant women. They also get renal failure. We've talked about the children, we've talked about adults, but the pregnant women, and for many of them, their only sin is that they were attempting to bring another human being into the world. And in the process of that, they get hypertensive disorders. And these hypertensive disorders then lead to renal failure. And among the causes of death among hypertensive disorders patients, eclampsia is number one. The second is acute renal failure. Now, acute renal failure, if they get prompt dialysis services, the kidney can recover completely. Unfortunately, this service is not on the NHIS as of now. And you wonder why it is not. So in reality, the solution is for this thing to be free. Now, for it to be free, we must have a mechanism for financing. One of the challenges with the financing mechanisms here is that if we talk of the NHIS will be a very good vehicle because they are experienced in managing funds as far as healthcare is concerned. They have all the actuarial statistics to prove how to sustain funds. But in a system where the NHIS funds are capped, which means that not every amount going that we have contributed to the NHIS actually gets to the NHIS or is disbursed to the NHIS. How can they get money to fund these services that we are talking about? We have imposed a sin tax on substances that we think are inimical to our health. The money coming from this sin tax, are we ring-fencing it to use it to cater for the people who fall victim to these substances? Because that's the whole theory around it. We know that smoking is not good. It will give you a non-communicable disease. Therefore, we tax cigarettes so that when you fall ill, you will not be a burden to the society. That burden that you would have brought onto the society by smoking, the tax that we have gotten from you, we can use to take care of you and other people who may need it. What are we doing to the money that is coming from this sin tax? Are we ring-fencing it, or is it just going into the consolidated fund for which it's very difficult for you to even account for? So if we are looking at it, I think ultimately dialysis must be free. And we have to have a funding mechanism. My other submission on this is that if you look at the kidney situation we are discussing, the prevalence of chronic kidney disease, about 17% in Ghana, means that this condition is even more prevalent than HIV. Has it gotten the needed attention like HIV? So we need perhaps a separate entity, maybe a National Kidney Health Authority or a chronic diseases or non-communicable diseases authority to engage in surveillance for these conditions, proper research on the etiology. In the case of kidney, for instance, what is globally known as a leading cause of chronic kidney failure is diabetes, but in Ghana, it's not. Mm-hmm. So what is different in the Ghanaian population? When you look at Ghanaians living in Ghana and Ghanaians living abroad, the prevalence of kidney disease among them is not the same. The leading causes is not the same, which means there are still a lot of unanswered questions. Capacity building. I think Dr. Nsiasa talked about building capacity of our surgeons. Dr. Opokwa Mpuma also confirmed that is very helpful. But as of today, we have just about 12 nephrologists in Ghana to cater for 17% of our population with chronic kidney disease at various stages. What are we doing to improve on that? So these are the critical questions that I think we need to be asking ourselves. And if we do not get these things well answered, we will have a big challenge at our hand that will be very, very, very difficult to manage. Finally, on the prevention, they've talked about the policy on wellness clinic. Evans, the dichotomy between our policy and the actual implementation, what is happening on the ground, is so clear and striking that you can just see the difference. As of today, there is no motivation for a Ghanaian just to walk to the hospital. We can keep appealing, but when they don't go, at the end of the day, we will have to bear the brunt as a nation unless we decide to do what we are doing now and leave them to their fate so that they die. But if we really, really want to make some diagnosis not a death sentence to a lot of families, like the end-stage renal failure is today to a lot of families, we must put in incentives to get people to go and get themselves checked. Have those who have brought this policy and implemented it found out why are people not going? How long are we going to keep appealing? Now, if you walk into any health facility and say, I'm just coming for a wellness check, and I run a private hospital, and I check your BP, I check this, I want to do a screening for diabetes, you have to pay for it. This wellness check is not on any insurance. Our health insurance scheme today, if you don't have a diagnosis, and a patient comes to the clinic and he said, the patient is well, you will not be paid. So what would be the motivation of any private or public practitioner calling people who are apparently well at home? Come and get yourself checked every year. So we must put in some motivation where the NHIS or private health insurance schemes are made to pay for at least one annual wellness check per year, per person. If that is happening, then there'll be motivation. Even the clinic owners or managers will put in a callback mechanism for people to come to the clinic to screen because there's a motivation for the facilities because they are going to be paid for that service that is rendered. As it is now, we are only appealing to people's conscience. And if I'm not sick, really, the thinking is that why do I need to see a doctor? Even though we realize that it's very important. So I think that if we really, really, really mean business, we have to look at incentivizing the system. But in summary of all that I have said, what will the Ghanaian get from their government? What is the benefit of paying tax to my government? So that things that I cannot do for myself, like provision of roads, the government will provide for me. I think in the health sector, the conditions that if you are diagnosed with today, no matter your income level, you struggle to survive. The renal failure, cancers, if you have an acute stroke, you need in ICU care. These very cost-intensive services, most of them are not covered on the NHIS.
And as
what will government do?
Yeah, and as we talk about the NHIS, I can tell you that we'll be talking to the National Health Insurance Authority next. And also Odisia Mensah is the Director of Corporate Affairs, will join us for that conversation. Nasiba Bawa is the protester you saw. A video went viral. She complained about the death of somebody that she knew and really got a lot of people talking. Also will join us with thoughts on this particular matter. And then also we will definitely go back and hear from Kojo and his panelists, the patients with him in the Joy 99.7 FM studio. You see them there waiting to have a bite at where we are in this conversation as far as the solutions are concerned. And in the studio with me is the Presidential Advisor on Health, Dr. Nsiasari. Dr. Adomako, of course, heads the Kolebu Teaching Hospital, and Perpetual Lizzie, President of the Ghana Registered Nurses Association as well. I know there's a lot you want to say to that. I'll come up for you to have it because I want to take a quick break.
No,
Do you want to? Okay, no problem. Very briefly.
Before we go for a quick break, there are some
very briefly.
There are some things that my junior brother.
So hold on to that. Hold on to those things. Just make a note. Make a note. I'll return for that. I'll return for you to give us your thoughts on what you've just heard. Please stay with us. This is a conversation about the dialysis crisis. But as you've heard, it's far bigger than that. When we return, we'll hear from the National Health Insurance Authority.